Okay, the last session before the final break, it's my pleasure to introduce Dr. Emmanouil Brilakis, who's been a friend and colleague of mine for 10 years, who's obviously a world expert in the arena of cardiac interventions, and he's going to be talking to us about intravascular imaging physiology.
Okay, thank you very much, Owen. So I have good news and bad news. First, the bad news. There will be no break, because realizing if you take a break, they will never get you back. All right, so you're here. The good news are you're free to go back. There's a lot of good snacks and desserts back there, so you're free to go, not all at once, please, to go and get some and come right back. So the other good news, we'll do the raffle for the book right after this talk, so while we're preparing for the panel. So there will be no break, but that means you'll go home earlier, because then you will have to stay for the break. So, and I'm pretty fast, so I'll try to go quick and get you through this, and then go to the fascinating part for today, which is the interactive discussion. Unfortunately, we scheduled them too packed, so we didn't have time to discuss, but finally, this is the time to discuss. So all the questions you've been having all day, now is the time to bring them up, actually after this session. All right, so intravascular imaging and physiology. Why do imaging and physiology? The answer is, what do you want to achieve? Do you want to achieve something using old-fashioned tools, like on the left, or do you want to use modern tools? You can still get it right with a bow and arrow, but if it were you hunting this day, would you use that method or that method? So why would we do it? And everything starts with why. And let's start with the first modality that's been around for a long time, which is the FFR, or fractional flow reserve. As you know, this is a technique to determine if a lesion is tight. Why do we need that? We need that because the lesions we think as interventionalists they're tight, and we think based on our visual assessment, actually it turns out that for the ones we think is between 70 and 90%, which would be tight ones under most angiographic criteria, actually a lot of them, about a third, are actually not significant. And some of the ones we think might be even less so, then some of them are significant, some are not. So one way to tell is by doing the FFR. This is a recent study from last year, the famous study. So about 1 in 5 patients got different management. It went either from bypass, as you can see, to PCI, or from PCI to medical therapy, or from medical therapy to bypass. So the therapy changed radically based on the FFR measurement. So in this day and age, you want to treat accurately the patients, we need to be sure that they have significant disease before we treat them. Why do we do that? Apart from improving outcomes, also what we know is that it reduces the risk of myocardial infarction and death, and the risk of subsequent adverse events, and it's cheaper. So not only you use less stents, but procedure is faster, you use less equipment, everything is faster and more effective. How about medical therapy versus PCI? So what we know is that with the Coherence trial said that if you have a patient with stable angina, whether you do PCI or medical therapy, outcomes are the same. But now we know that many of the people we think have severe disease, actually they do not. So the FAME2 trial was done, which compared medical therapy to PCI guided by FFR. And guess what, when we did that, then the incidence of death MI and unplanned hospitalization with death vascularization was actually higher in the group that got medical therapy. Now, the death and MI were not different. The difference was concentrated mainly in the urgent revascularization. However, many of those patients came back with events, and at 2 years follow-up, we just published in New England this year, people who got medical therapy continue to have more events compared to those who treated with FFR-guided PCI. We are currently participating in FAME3 and syntax quiz going on in Europe. So actually, we're comparing once again bypass with optimal PCI guided by FFR. Now, FFR can be logistically a little tedious because you have to put a wire down the artery and you have to give vasodilation with adenosine. So can we get rid of the adenosine, which has caused and make the people have symptoms? There are two alternatives proposed in the last few years. One is a simple ratio of the distal to the proximal pressure in the coronary artery. And the other is the IFR, which measures the pressure in the diastolic wave-free period. So one way to see if resting hemodynamics can tell us the same information as if we're using the adenosine. And this is the RESOLVE trial, again published a couple months ago, which compared this to the gold standard FFR, and what we're seeing is if you want to have 90% accuracy, you can avoid giving adenosine in half the patients. But if you want to have 95% accuracy, then it's only about a third of the patients in whom you wouldn't give adenosine. So seems to be promising, but still we'll need much more data before we're able to determine their use in the cardiac cath lab. There is a new Ffr catheter that is based on a microcatheter, not a wire. So we maintain our position, and that's currently being available. And there is also new technologies that allow you to do the FFR based on computed tomography imaging. So you don't even have to go to the cath lab. Obviously, that's ideal, but still we're not there yet. What we found out, the collaboration with our European colleagues, is that actually, if you take the angiogram alone, you get with decent accuracy determine the FFR based on computational fluid dynamics. This is a great area of those of you with insomnia at night. It can really help you. And it's extremely complex equation. To give you an idea, to do this, it takes a pretty powerful supercomputer about a day. So, still not live, not real time yet, but the way computing is improving, I think in the next few years, we are going to see this being more and more down in the forefront, where just taking the angiogram, fitting in a computer, can do the FFR without putting a wire in. Moving on, intravascular ultrasounds. Time-tested technique can really help us determine the significance of left main disease, can help us on multiple other areas, such as determining rare variants of coronary artery disease. There were 4 meta-analyses published last year regarding IVUS-guided intervention versus angiographic-guided intervention. And in all of those, there was significant improvement in outcomes, both myocardial infarction and death. There is a big study called ADAPT-DS that was observational, so not a randomized trial, but still so the same thing. If you use intravascular ultrasound, you're going to have less stent thrombosis, you're going to have less myocardial infarction, and the main reason behind this is because, as we saw last night in the symposium, when you don't do IVUS or some sort of imaging, quite often you don't expand your stent very well, or you don't detect any other problems such as distal left dissections or thrombus forming inside the stent. So by doing intravascular ultrasound, you can optimize your acute result, which can translate to improved long-term outcomes. We do a lot of CTO-PCI, as you heard this morning, and IVUS is very important to determine where to start the lesion, guide our wiring, guide the size of stents we're using, and assessing if we have any complications, and we do that with a short tip IVUS catheter. So there are many, many ways we can use this. This is an example of a CTO in the right coronary artery. We couldn't decide exactly where the vessel was starting. By doing intravascular ultrasound, we actually discovered where the vessel was. And then, as a result, we were able to take care of it. Is there any improvement in IVUS? Yes. After a very, very long period of time, we are finally having several companies, you can see it on the slide, are developing new HD IVUS. Now, HD IVUS is much more expensive than HDTV, for those of you who buy those for home. However, it does significantly improve the quality of the image and the resolution of the image at the cost of slightly less penetration. So you can see here some images obtained with the new generation infrared catheter. You can see a much nicer separation between the intima and the media, and you can see the stent much more clearly than you could before. So in a way, this is bridging the gap between the standard grayscale IVUS with the OCT, which I will discuss in the next few slides. So OCT, or optical coherence tomography, another very commonly used intravascular imaging technology. Instead of using sound, it uses light, which means you have to clear the vessel, so you have to give some contrast or dextran to clear the vessel from the blood, because the blood is red and absorbs the light. So it doesn't penetrate very much, it goes on the wall, then cannot penetrate very much, but the resolution you get is about 10 times better than the resolution you have with intravascular ultrasound. This is an example of an OCT image in which you can see that the image wall can be seen with extreme clarity, and you can see things like thrombus, like dissections, like stent malapposition that is very hard to see with intravascular ultrasound. And again, by using dextran, we can do this without giving contrast, which has cost and the risk of contrast nephropathy. OCT can be used in multiple ways, as can IVUS, but the bottom line is for standard PCI, we need 3 things. We need to know how big is the vessel distal to the lesion, how big is it proximal, and how is the lesion, and what's the length of the occlusion. Based on this, you select your stent length and stent size, and then you're much more accurate and much less likely to be under or oversized. You can detect the culprit lesion in a patient with ST elevation or any sort of acute coronary syndrome. As you know, sometimes the patient comes, we do an angiogram, and we don't know, okay, what's the problem? Sometimes it looks so good, we're debating, is the patient saying the truth? But sometimes, actually, the patient is saying the truth and the enzymes are positive, but the lesion is so geographically is not visible. You do OCT, you can find exactly where the culprit is. You can see the thrombus, the rupture of the cap, understand what's the problem. You can see dissections after you put a stent. You can see the stent not touching the wall, which is called stent malapposition. And again, it's the thing we want to correct for improving the long-term outcomes. So this is an example of a case where we did a stent and we weren't sure what was going on because the flow was not the best. And then we did OCT, and you can see very nicely that the vessel distally is not, this is actually the vessel right here. The vessel is here compressed because actually our catheter or our wire has gone in the so-called subintimal space. So this is something you cannot see by IVUS, but you can only see with OCT, and it very clearly explains to you what the problem is, and putting a stent is how we fixed it. Here's another example, it comes from Chicago, VA. We see a funny picture in a patient who had a stent a month ago in their lab. And they did OCT, and they found this little tube sitting in the coronary. They took it out, and guess what came out? This little plastic tube. Clearly, that doesn't belong there. So apparently, and you know what the thing is? This is actually what covers the stent. When it comes out of the factory, it comes nicely packaged in this plastic piece. Now, the instructions for you say, take it out before you put the stent in. But clearly, the operators didn't realize that, so they left it in. But thanks to Dr. Vidovich, they took it out afterwards and got the great result. But these are, again, things you couldn't understand without having the capacity and the nice imaging resolution that OCT gives you. This is another example. This is a patient with a CTO who brought back because of angina, and interestingly enough, we couldn't get anything down the coronary. Like, what's going on? It's a big vessel. And of course, you do an OCT and you see, we're not going through the stent, we're going around the stent. So actually, we're compressing the stent, not good. So we're able to take care of this and get good results. And there's one observational study saying that if you do imaging to optimize your results, actually you reduce the risk of major adverse cardiac events down the line. There are more exciting things coming, such as OCT and angiogram co-registration, where actually literally walk down the coronary artery and see the corresponding image on OCT, which makes life much easier and much more intuitive to understand what's going on in the coronary. Moving on to near-infrared spectroscopy IVUS. If I go too slow, please let me know, I'll go even faster. So here is an example of how we have a combined catheter. This is the only commercially available combined catheter. It has two components. One is a standard intravascular ultrasound that gives you this grayscale image. The second, it's a laser. Actually, it's a similar laser than the one used in OCT, but we don't use it for imaging. We use it to determine the composition of the coronary artery wall. It's used a lot in chemistry, in oil extraction. This is a great method to determine the composition of a substance based on how it reflects and how it absorbs the near-infrared light that is shed on it. So based on this, we know not only we don't get the information only for the intravascular ultrasound, the image of the artery, but also we can see how much lipid there is. So it's very simple. Yellow is lipid. Too much lipid is bad. Simple as that. And if you have a lot of lipid, why is it bad? Because you're more likely to get post-PCI myocardial infarction, because this lipid may go downstream and block up the artery and cause more damage. It's because when you have the lipid and you put a stent, the contact of the blood with this lipid can actually form to thrombus formation. What you're seeing here is thrombus forming inside the stent real time. Not good. You can take care of this before it completely occludes the vessel and causes acute stent thrombosis. Moreover, we know that the areas that do have lipid are more likely to progress and cause problems down the line. It's a great way to assess therapies for atherosclerosis. And this year, for the first time, we had two studies showing that if you have a lot of non-stented areas that have lipid, then they have a higher likelihood of events and getting more problems. And we actually have several prospective trials going on. There is the LRP running in the US, there's a Prospect 2 in Europe, and we're running one within the VA system, which is looking at the natural history of atherosclerosis and telling us how we can use this to optimize clinical outcomes. And We had a wonderful workshop with many colleagues from the VA, and we welcome all of them and anyone who's interested to join this effort, which I think is going to give us novel information on how to optimally use this technology to optimize clinical outcomes. Now I'm going to show you Lauren Mackey performance. So Lauren Mackey is one of our techs, which is super expert in preparing and getting everything ready in both IVUS and OCT. So we want to see how fast can Lauren do it. So we videotaped her. We got consent first. And then, after getting consent, we videotaped her. And she was a little stressed. She was going a little slow for her usual. But still, she was able to prepare a solid state IVUS in 27 seconds. Took a little longer for the OCT. But still, this answers the question, how tough is it? The answer is, if you have Lauren, it's very, very quick. All right? Having said that, if any one of you try to get Lauren, you're going to have a big trouble from Subhas and I. So don't touch Lauren. But the answer is, it doesn't take that long as you think. If the lab knows how to do this and is experienced, you can do this very, very quick and get the answer you want. And the machines are running. It really takes 2 to 5 minutes to get your OCT or your FFR, and everything is going to be great. So to finish it up, you have several technologies available to you. Some of them are good for one thing, some for another thing. For lesion significance, FFR remains the gold standard. That's what we do, and that tells us if the blockage is tight or not. And then for optimizing the result of the procedure, intravascular imaging with spectroscopy, IVUS spectroscopy, optical coherence tomography, grayscale IVUS can make us get the best possible result. And then finally with OCT and near infrared, we may be able to predict what's going to happen in the future. But that information will be available next year, so you better make it up to CVI 2016. So thank you so much.